Here I will discuss the clinical features of Down syndrome and then later discuss in details the mechanisms through which Down syndrome can develop. So Down syndrome is the most common chromosome abnormality, which is due to trisomy 21. It's also the most common cause of mental retardation. Clinical findings of Down syndrome include epicanthal folds, which are shown right here, upslanting palpebral fissures, which are shown right here, low set ears, as well as flat faces. The other feature is simian crease, so there is a single transverse simian crease, versus in normal individuals, which there is usually two creases that are like this. So in these patients, there is a single transverse simian crease. The other findings that are usually present in Down syndrome include atrioventricular septal defect in about 37% of the patients, ventricular septal defect in about 31% of the patients, and atrial septal defect in 15% of these patients. So these defects is due to the failure of neural crest cells to migrate, and thus since there is problem with endocardial cushions, then there would be lack of these septums in the heart. In addition, due to the failure of neural crest cells to migrate caudally, there would be failure of formation of autonomic ganglia in the Meissner and Auerbach plexus, as a consequence of which these patients will have aganglionic colon. So what happens is that they would have regions of the colon that are aganglionic and would not be able to relax, and that would correspond to this region. And the segment proximal to the aganglionic region would be dilated. So here would be normal segment followed by an aganglionic region that cannot relax. So therefore, these patients present with failure to pass meconium, bilious vomiting, as well as abdominal distension. Another possibility is duodenal atresia. So during embryonic development, the duodenum needs to be recanalized. And if there is failure of recanalization, then there would be duodenal atresia, as a consequence of which these patients develop bilious vomiting, as well as polyhydramnios during pregnancy. So since there is duodenal atresia, the fetus cannot eat the amniotic fluid, and thus the amniotic fluid keep building up. There would be increased volume, which causes polyhydramnios. And one final finding is called double bubble sign. So it's called double bubble sign. And what it means is that when you take an x-ray of these patients, so here is the head, then here is the torso. So if you take an x-ray of these patients, what you see is that two black bubbles. And these are referred to as double bubble sign, which is characteristic of duodenal atresia that is commonly present in patients with Down syndrome. Another finding is acute lymphoblastic leukemia, also known as ALL. So the chance of developing ALL in these patients is about 10 to 20 times higher than normal individuals. And finally, these patients are at increased risk of developing Alzheimer's disease, and the reason for that is that the gene amyloid precursor protein, also known as APP, is located on chromosome 21. So these patients have 3 copies of APP. So there is a higher chance that this gene can get mutated and form the amyloid beta plaques, which can lead to the development of Alzheimer's disease. Now, there are diagnostic tests that can be done for Alzheimer's disease, and these include the measurement of maternal serum values for alpha-fetoprotein, estriol, beta-HCG, and inhibin. And the findings that you will see is that reduced alpha-fetoprotein, reduced estriol, but increased beta HCG, and increased inhibin. So the kind of mnemonic that I use to remember which of these values of the quad test, so this whole test is referred to as quad test, and it's being done early in the second trimester of pregnancy, and the values are obtained by measuring the lab values in the maternal serum. So back to the topic, the mnemonic that I use to remember which of these values are elevated in Down patients is HCG and inhibin, so H and I remain high, HI and then GH in these patients. Okay, now that I discussed the clinical features of Down syndrome, I would like to discuss the mechanisms through which the Down syndrome can develop. And these include non-disjunction of homologous chromosomes, Robertsonian translocation, as well as the mosaicism. And non-disjunction accounts for 95% of the cases of Down syndrome. Robertsonian translocation accounts for 4% of the cases of Down syndrome, and mosaicism accounts for 1% of the cases of Down syndrome. Now I would like to go over the mechanism and discuss these clinical features with you. So the first mechanism is non-disjunction of homologous chromosomes, so non-disjunction. So during the replication of gametes, there has to be two phases, meiosis 1 and meiosis 2. And non-disjunction of homologous chromosomes can occur at either phase, either in meiosis 1, which is shown here, or meiosis 2, which is shown in here. So normally, one pair of chromosomes should go to this cell and another pair to here. If there is non-disjunction during meiosis 1, all of them will come here, and then once they divide, still both gametes will have trisomy 21. So these are non-viable since they have no chromosome 21, and then these ones will both lead to the development of trisomy 21 or Down syndrome. So these eggs from mother, when combined with another chromosome 21 from sperm, will lead to 1, 2, and 3 copies. So all these patients that have non-disjunction during meiosis 1 will develop Down syndrome. However, if there is non-disjunction during meiosis 2, one of these would be not viable and die, 2 of the gametes would be normal, and then 1 out of 3 would be abnormal and lead to Down syndrome. So just keep that in mind. If their non-disjunction is in meiosis 1, 100% of the gametes will lead to the development of Down syndrome, versus if it's in meiosis 2, then only 1/3 will lead to the development of Down syndrome. Now I would like to mention that non-disjunction is very closely associated with increased maternal age. In addition, here I've given the example for chromosome 21. It could be for chromosome 18 or chromosome 13 as well. Now, one question that may arise is that how come you don't see trisomy 15 or trisomy 4, for instance? And the reason for that is that these fetus will die before they're born, so you will never see those kind of trisomy. So the only viable ones are trisomy 13, 18, and 21, which are related to the advanced maternal age. The next mechanism is Robertsonian translocation. Now there are certain chromosomes that are called acrocentric, like chromosome 21, which have a short arm and a long arm. So it's the long arm that carries most of the gene, and the short arm is non-significant. So if it gets lost, it's not a big deal, and still the patient will be normal. So if there is a translocation of chromosome 21, so let's say for argument's sake that this chromosome breaks right here and goes and add to chromosome 14, so that would be the new combination. And then the short arm gets lost, which is not a big deal. So that would be the new combination that would be formed here. And if gametes are formed from these chromosomes, these would be the 4 combinations. So let's assume we had this small one here, not get lost, so the short arm could get lost or remain here. So the combinations that we would get would be this first one with the normal one, that would give the first one. Then it would be this normal 21 and the translocated 21 and 14, which would be this one. Then it would be the short one and the translocated one, which would be this one. So the short one is not here because it's not significant, or it could get lost. And then the final combination is the short one and chromosome 14, which is right here. And then again, the short one is not shown. Now, normal gametes that are formed will have 121 and another 14. Now, if you combine these combinations, what you will get is monosomic 21, which are all lethal. So there would be 3 combinations that remain. 1/3 would be normal phenotype because they have 2 21 chromosome and 2 14. Another 1/3 would still be normal, so it would be a normal phenotype, but they are carriers of translocated chromosome. So they have the translocated chromosome. But if you do the count, you will find out that they have 1 21 and another 21 here. So they have 2 chromosomes of 21 and 2 chromosomes of 14. So the phenotype remains normal in these patients. And then finally, 1/3 of these patients will have 3 chromosomes of 21. 1, 2, 3. So trisomy 21, which leads to the development of Down syndrome. One important point is that these patients have still normal number of chromosomes, 46, versus non-disjunctions, which they had 47. So these patients still have 46 chromosomes, but there is an extra attached chromosome of 21 to one other chromosome. The next phenomenon is mosaicism. So what happens is that in post-fertilization, so here, sperm and the egg have fertilized, formed the zygote. If post-fertilization there is an error and trisomy 21 is formed, then some of these cells will only have the trisomy 21, and thus they will have 47 chromosomes, while the other cells would be normal. And so these cells would have 46 chromosomes and normal. So once the adult individual is formed, there would be 2 types of cells, normal 46 and then the abnormal 47 chromosomes. And thus these patients will have another form of Down syndrome. But this is very rare and accounts only for 1% of the cases of Down syndrome. Okay, now let's go through this table and fill it together. Non-disjunction accounts for 95% of the cases of Down syndrome and is associated with advanced maternal age. Robertsonian translocation accounts for 4% of the cases of Down syndrome, and mosaicism accounts for 1%. Now, if you look at mosaicism, there are 2 kinds of cells that are present, 47 chromosomes versus 46. So therefore, the number of chromosomes that we have is a combination of 46 and 47. With Robertsonian translocation, as we discussed, there is normal number of chromosomes, 46, despite there is an extra copy of 21 attached to one other chromosome. So therefore, these individuals will have 46 chromosomes, and then non-disjunction will have 47 chromosomes. So let's go back to the top. So here, as we discussed, there are 2 copies from the mother. So 1 right here, 2 right here, and then another copy comes from the sperm, making them 1, 2, 3, trisomy 21 with 47 chromosomes. And that concludes our discussion.